Yeah, hi, good afternoon, everyone. After this perfect surgery, now it's time to manage the patient.
Yes, we need no good as a team. Wait, that fits.
इसको नीचे कैसे? Now, as we know, after bariatric surgery, we have to keep the patient on the liquid diet for 1 week, and after 1 week, we have to proceed on the full liquid, and then third week, we have to keep the patient on the soft diet, and then after 1 month, patient has to be on normal diet after MGB. But these diet things are very easy. We can make the protocol, but after following this, the patient come across so many complication that I am going to address here. What I have seen in my practice, the most common is the abdominal pain. Patient used to give the complaint of the abdominal pain, constipation, protein calorie malnutrition and sarcopenia, patuous Eustachian and bacterial overgrowth, metabolic bone disease, anemia, neuropathy, vitamin and mineral deficiencies. These are the most common complication which we find after this surgery. Let's talk about this today, about the abdominal pain. What could be the reason for the abdominal pain? It could be just because of the bezoar, change in bowel habit, small intestinal bacterial overgrowth. These are the reasons for the abdominal pain. I am going to address each of these in further slides. Patuous Eustachian is also a kind of complication which is very common after this MGB procedure. And protein calorie malnutrition and sarcopenia is also very common. If we are not taking the patient, we are not doing the follow-up, vigorous follow-up, then it is very common. And the next is the micronutrient deficiency. It is a very vast topic, but I will try to address it. Abdominal pain. There could be reason for there could be medical or surgical reason as well as the nutritional behavior also. Disorder related to the pouch stomach or remnant stomach. Disorder related to the hepatobiliary, large intestine disorder of motility and functional disorder. Whereas dietary, it could be eating mechanics because the patient are in the habit of engulfing the food, and post surgery also they want to follow the same habit. Food intolerance and micronutrient and macronutrients are also deficiencies, also very important reason. Have you ever seen this complication in bezoar? Is the not very common. If we have to educate the patient before the surgery, and pre-surgery counseling is very important so that the patient should know this complication can happen. Here is the study. Here is the scan of this patient with the bezoar. Bezoar could be a food or medication or supplementation. Food. There are so many foods like even the coconut and oranges, figs, berries, grapefruits. We have to avoid we have to ask the patient to avoid these foods. Vegetables like celery, green beans, legumes, potato, seeds like watermelon, sunflower seeds, and there are some medication that is also can cause the bezoar formation. And now, what is the treatment for the bezoar formation? Sometimes surgery is also required. Sometimes it can be removed through endoscopy. It's a very interesting evidence to use the cola for bezoar treatment. Here, there are different kind of treatment modality that medical nutrition therapy available for the bezoar formation, bezoar treatment. How to prevent? First of all, the pre-surgery counseling is very important. Next is discuss food that have a risk of developing into bezoar, like coconut, popcorns. All these foods we have to teach the patient not to take after the surgery for a few days. Second is the change in bowel habit. As it is malabsorptive surgery and the transit time is very fast, even in the malabsorptive process also, in some patients we are finding the constipation problem and diarrhea problem. These two are the very common problem which we are facing after the surgery. Patients are complaining of. Diarrhea, it could be because of the lactose intolerance, dumping syndrome, bacterial overgrowth, eating mechanics. Constipation because the patient is not taking enough fiber, and it can cause the constipation. Even after reminding so many times, patients are not taking the adequate fluid, and we have to emphasize that because in one go they can't be able to take. That's why we have to educate them to take sips after every short period. High protein diet supplementation can also cause the constipation. Inadequate exercise. According to the guidelines, it's important to walk for the 30 minutes so that the peristalsis movement can increase and the patient can avoid the constipation. Research shows that the bowel habit change after bariatric surgery. Some studies show that up to 75% patient report changes in the bowel habits after bariatric surgery, especially gastric bypass surgery, either in RYGB or MGB. Severity and type depends on the type of the surgery. In the AGB list, constipation is there. 88% to 27% in the RYGB constipation or diarrhea, and from 6.8 to 60.2% in BPD diarrhea. Why does this happen in bariatric surgery? Dietary exercise, less fiber, and I told you less fiber intake, fluid intake, exercise restriction, limitation. Patients complain that they are feeling weakness and they can't exercise. And pre-existing conditions, sometimes IBS or other GI disorders. Physiological, it could be change in the bile acids, change in the gut hormones, change in microbiota, change in gut motility. Some opioids can also cause the constipation. Even the patient, some patients are taking the painkillers even after the surgery, and this it can cause the constipation. Even age is also important factor. Constipation and flatus is the greatest reported bowel issue. Some patients are complaining of constipation, but how we can recognize that it's an actual constipation or not? According to the National Institute of Diabetes and Digestive and Kidney Disease, constipation is defined as having a bowel movement fewer than 3 times per week. And constipation stools are usually hard, dry, small in size, and they are difficult to eliminate. Dangers of constipation can lead to the hemorrhoids, fissure, and rectal bleedings. How we can remove the constipation? Fiber is the most important player in this. In a systematic review by the Gross and Cope, the researcher found dietary fiber intake is reduced regardless of the surgery type. Whether it is a restrictive or malabsorptive, fiber intake also always reduced. However, after 2 years, fiber intake ranged from 10.5 to 11.7 grams per day. There are 2 kinds of fiber. One is soluble and one is insoluble. Insoluble fiber can form the bulk, and the soluble fiber can dissolve in water to form a gel-like material. And both fibers are important to cure this. The fiber, here we can see the fiber-rich food, like all kind of beans and legumes are the richest source of the fiber. Even a sweet potato, cauliflower, and banana, quinoa, all these are the good sources of fiber. Resistant starch is very important. You will be resistant starch also play a very important role in lowering the glycemic index of the food. And if we keep the cooked rice in a freeze for 12 hours, and if we will use it next day after 12 hours, then we can find that the resistant starch will increase and it will become equivalent to the brown rice. So we have to give the resistant starch to the patient to avoid the constipation. Physiological effect of resistance: improve glycemic and insulin response. Even in the diabetic patient, it is very important. Metabolic, in all kind of metabolic syndrome. Improve bowel movement. Improve lipid profile, prebiotic and production of short chain fatty acid. Increase satiety and reduce energy intake. Increase if the fiber is for the longer time in the gut, then the calcium absorption can increases. It can also induces thermogenetic effect. Fluid is very important. Though patient are compromised of taking the liquid at this time, we have to we have to educate the patient to take the liquid in different form. In some of the patient after surgery, they can't be able to take the plain water. We have to encourage the patient to take the coconut water or change the temperature of the water, like popsicles or lukewarm water. Patient can easily take, but the normal water patient always complains of taking, not taking adequately. That's why we can modify, we can understand the patient problem, and we can modify. Just because of the dehydration, most of the time patient complains of the fatigue and weakness, and we have to understand the reason, and we have to treat the patient accordingly. So education is the most important factor. It is the cornerstone, and at every point of time we have to educate the patient. In each follow-up, we have to educate the patient. Bacterial overgrowth is very common. There are so many reasons for the bacterial overgrowth. How we can know about the SIBO in the patient? Small intestine bacterial overgrowth is defined as the presence of excessive bacteria in the small intestine. Defined as a bacterial population in the small intestine exceeding 10.5 to 10 to the power 5 to 10 to the power 6 organism per ml, and we can calculate, or we can find it through the hydrogen breath test, or prevalence of SIBO is approximately 2.5% in the lean individual versus up to 15% in obese individuals. Other studies indicates that ruined gastric bypass is an independent risk factor of SIBO. SIBO can develop when the normal homeostatic mechanism that controls antibacterial population are disrupted. The three processes that most commonly predispose to the bacterial overgrowth are diminished gastric acid secretion, either it could be surgery or medication, some intestinal motility, gastroparesis, DMs, scleroderma, disturbance in the gut immune function. How we can find the symptoms? Frequently implicated the cause of chronic diarrhea or constipation, steatorrhea, nausea, cramping, poor appetite, fatigue. Sometimes patient also complain the vomiting, and there are some nutrition factor also that is very we have to consider. Here is one of the good study that says that if the serum folate level is low in the and thiamine level is low, when the thiamine level is low, serum folate can increases, and that can cause the bacterial small intestinal bacterial overgrowth. And patient with SIBO may also suffer from the nutrition deficiency, including fat malabsorption, carbohydrate malabsorption. Related consequences of the vitamin and mineral deficiency, it would be anemia, metabolic bone diseases, peripheral neuropathy, very bronchitis, encephalopathy, vitamin deficiencies, B1, B3, B12 is very common. And mineral deficiency, calcium and iron is very common because the less gastric acid production is there. Either it's a restrictive or malabsorptive, or the absorption site is also bypassed. That's why these nutrition deficiency is common. Gold standard is endoscopy with the jejunal aspiration, so showing greater than 10 to the power 5 organism per ml. And then another tool is glucose breathed hydrogen test. If it is more than 12 ppm above the basal, then it SIBO can be bacterial overgrowth is there. And the treatment is correct the underlying cause, nutrition guidance, and antibiotics. In some cases there is a requirement of the antibiotic, that's the rifaximin. Nutrition guidance, correctly there is no strong evidence-based diet for the SIBO. Only we use the FODMAP. In this case, FODMAP is a fermentable oligosaccharide, disaccharide, monosaccharide, and polyols free diet to the patient. Sometimes gluten-free diet also depends upon the patient symptoms. We can suggest an elimination diets, lactose-free diet. Therapeutic diet is a combination of the FODMAP and a specific carbohydrate diet, which limits specific sugars such as starches in the combination with fruits and vegetables. Like some patient having the apples, that is sorbitol in the apple can cause the diarrhea. Sometimes patient can't be able to take the mushrooms, or these are the cauliflower families, or in this case we have to take the history, and accordingly we have to modify the diet. I told you lactose-free, low sucrose, fructose diet, polyols, even the chewing gum and all can also cause this problem. Elimination diet to determine tolerance to starchy food, low fat. A probiotic is a combination, and probiotic is also very important. Though the study, there is no strong study, but we are suggesting the patient to have probiotic. Sarcopenia is very important, and how to correct sarcopenia and how to avoid sarcopenia, it is very important factor. Sarcopenia could be age related, but here low in bariatric patient we are finding just because of the low vitamin D and the not taking the adequate protein can cause the sarcopenia. Nutrition to gain muscles. These are the evidence-based. If we are giving the protein, that 1.2 gram per kg per day protein requirement is should be there. Leucine 3 gram per day for building the muscles. Beta hydroxybutyrate 2 gram per day. Creatinine 0.3 to 0.5 gram per kg. Vitamin D 800 to 1000 IU per day, and long chain omega-3 fatty acids. It should be in the 1.86 to 1.50. It can help in building the muscles. There are so many guidelines, and each guidelines is saying emphasizing on the protein. Post-bariatric surgery, especially in the malabsorptive procedure, we have to provide adequate protein, and protein should be the high biological value protein. Even in the if patient is compliance is not with the protein, then we have to we should not go for this malabsorptive surgery. We at the time of the counseling only we have to avoid these kind of, because the patient will be landed up with so many complications after surgery. I will tell you the few case history also. Leucine-rich foods are lean steaks, soybean, firm tofu, cheese, chicken, fish, seafoods, and beans, nuts, and seeds. These are the richest source of leucine. And pre-exercise and post-exercise, patients should take these things. And exercise is very important to build the lean body mass. Without exercise, we can't build the muscles. These are the vegan sources of the protein. Though only the soya, tofu, and all these are the good sources of protein. Legumes somehow not good sources of bioavailability of the protein is not good in these legumes, but still we can give take to practice guidance. Treatment of sarcopenia. Protein minimum 60 to 18 grams for females and 80 to 120 grams for the males. Focus on leucine rich food. Even the carbohydrate is also very essential to avoid the sarcopenia. In order to protein is sparing effect, we need carbohydrate. Minimum 150 gram of carbohydrates is recommended. Fat should be there. We can't avoid the fat. If the patient is obese, we can't say you should avoid. Even in the this mini gastric bypass surgery, the vitamin A, E, D, E, K deficiencies are very common. That my next slide will tell you how even we can't identify the reason and proper treatment. Just we are taking that patient is just complaining, but we have to take it seriously whenever the patient is complaining. Patulous Eustachian. What happened here? Here the fat muscles. Whenever patient starts losing weight, the fat muscles decreases, and there Eustachian tube remains open due to a loss of fat tissue and surrounding the cartilaginous portion of the, and the patient complains, start complaining, autophony, oral fullness or pressure, and sometimes patient also can't understand can't define these problems, but time to time patient if the patient is losing more than 20% of the weight, excess body fat, then we have to evaluate these things also without the First cited case in the bariatric literature published in 2019 by Alhamdi. 141 patients with GBP were studied by UNAS and symptoms and clinical sign of PT is presented in 21.28%. Patient who developed PT decreases a mean of 48.63 kg in average time of the 12.11 months. What happened after some time when the absorptive capacity increases, then these decrease in these deficiencies also happen. In a more recent study by Pascoto, the researchers note that 43.7% of the patients who underwent bariatric gastric bypass had symptoms of PET by 6 months post-op. Weight loss average at this point was 36.5 kg. What we can do? Low protein, it could be just because of the low protein intake, low vitamin A level, and perhaps low normal B12. When patient complain, refer to ANT, correct protein status, and additional vitamin A 5000 IU per day. Encourage vitamin A, rich food, encourage fatty acid intake, add additional B12, avoid caffeine, alcohol, and low sodium. Micronutrient deficiency. Research suggests that prevalence of micronutrient deficiency is increasing while monitoring of the patient at follow-up is decreasing. These all are the evidences that established deficiency after micronutrient deficiency after the mini gastric bypass procedure. These are the absorption site, and as we are bypassing this, we can develop, and there are probability of getting these micronutrient deficiencies. Preoperative nutrition deficiency is most common, as the hepcidin, we all know, is inhibit the absorption of the iron even in the obese patient not undergoing bariatric surgery. I'm seeing the transferrin saturation is even lower than 6%. And serum ferritin is high. Serum ferritin is not a marker because whenever there is a obesity, there is an inflammation, and just because of the inflammation, serum ferritin increases. That's why we always have the transferrin saturation as the marker for the this iron deficiency in these patients. Pre-existing deficiency, B12 deficiency is very common. Neuropathy is very patient. If we clinically see the patient or a patient, we take the history, we always find this deficiency. These are the recommendation by different guidelines that I will tell you in other slide in a short. Counsel your patient as if we will never see them again after their first post-op visit. Because we have to tell them everything. Otherwise, if the patient is not coming for the follow-up, if they will come to us, they always come to us with such a condition that even the life-threatening condition can also happen with this patient. That's why we have to tell them everything. If the patient required intravenous supplementation, then 1 liter bag of 0.45% of sodium chloride to be infused intravenous. And these 1 ampule of multivitamin, 1 milligram of folic acid, 100 milligram of thiamine, and 1 injection of 1000 mcg of cyanophylamine should be administered. All the patient after undergoing bariatric surgery, they require these supplementation. If the patient compliance is not good with the tablet, we should ask them to take the sublingual or nasal spray that is 350 mcg once a week is also quite can avoid the complication. Elemental iron 45 to 60 milligram. Just most of the patient complaints of the after taking the iron, they complains of the gastritis and acidity. We have to give the iron in the form of iron bisglycinate that will not cause these problems, and the compliance, we can increase the compliance of the patient. Calcium should be the divided dose. We should not give more than 500 mg calcium at a time, and it can calcium requirement can increase from 500 mg to even 1200 mg in some cases. Things to consider: bariatric formulary preferred. The bariatric supplementation, just because of the cost issue, patients are not taking. That's why we have to select in order to avoid the non-compliance, we have to select the easily available supplementation which is available. We should give to the patient as per their requirement. Bariatric beriberi peripheral neuropathy, folic acid deficiency. I'm going to in this, even in the any kind of the sleeve gastrectomy or mini gastric bypass patient, if patient is vomiting, then this thiamine deficiency is very common. Without any test, we should add, because thiamine is a vitamin, water soluble vitamin. We should administrate thiamine immediately intramuscular to the patient. The requirement as per the ASMBS guideline, 600. This thiamine is required only 1.1 to 1.2 mg in our for us, but for the bariatric patient, this requirement increases up to 600 mg. And we have to give if the patient is having the vomiting issue or something, without any test, we should give 600 mg of the vitamin for the therapeutic dose, and after that we can taper it to 100 mg thrice a day. Sometimes patient are coming with a syncopal attack and all this. We are doing the MRI, we are doing all the things, but we are not addressing this thiamine deficiency. And patient is patient, and these long-term negligence can cause the non-repairable damage to the patient. Suggested B1 deficiency and repletion doses on severity deficiency: oral 100 mg VID or TID as per the patient deficiency, 200 mg thrice a day or 500 mg BD 3 to 5 days, then recommended 100 mg daily on the prophylaxis dose, and 250 mg once daily for 3 to 5 days, and 100 to 250 mg monthly if the oral dose. Peripheral neuropathy. Always patient says that there is a tingling sensation in their hand and feet, or numbness, muscle weakness, shooting or burning pain. Even in the thiamine deficiency, also this burning pain is there. And the patient who is not reducing their alcoholic intake post-surgery also having these kind of issues. B12 deficiency can lead to the anemia, neuropathy, and abdominal pain. Even sometime we are finding the B12 levels are quite high in the patient, 1000 mcg. B12 deficiency can also masked by the increased folate deficiency. That's why we have to check in order to check the accurate B12 deficiency, we have to check the methylmalonic acid test we have to do, or either we have to do the homocysteine test. Folic acid test, folic acid deficiency is more common in patient. We have to more careful in those patients who is under planning for the pregnancy, and we have to closely monitor these patient. Metabolic bone diseases, osteopenia, osteomalacia, and osteoporosis, most common one. Hypocalcemia. How we can check the calcium deficiency in the patient? How we usually check serum calcium is the adequate marker for the calcium deficiency. In serum calcium can give you the idea about the calcium deficit.
Better deserve that. Bone just
Either ionic calcium, ionized calcium, or ionized calcium, or sometime PTH can also give us the idea of if the parathyroid hormone level is coming high. Then also it can. Sometimes alkaline phosphate is also very high in this patient. This can also give us the idea about the calcium deficiency. Vitamin D deficiency is very common, and in order to correct the calcium deficiency, we have to give the vitamin D supplementation also.
was there the unprotected we got.
Yeah. And just in order to avoid the toxicity, we can suggest the patient to take it for the 8 weeks. After that, taper the dose and discontinue for the 2 months, and again they can start if they are not going for the regular blood investigation.
Randomly with them.
Follicles.
What is
60,000 IU per week. Yeah. 8 weeks we usually, for 8 weeks per week, and after that we taper the doses twice a month, then once a month, and discontinue for 2 months, and again patient can start. If they are not doing, even they are not testing it, then also they can start. Food high, as we all know, food high in calcium are dairy product, tofu and soy milk, fish with bones, green veggies and legumes. Anemia is also very common after the bariatric surgery, and it can be iron deficiency anemia or iron deficiency. And it could be iron, and the major micronutrient that is responsible for that: iron, copper, B12 and vitamin A. The common sign is fatigue. Patient always complains of tiring. Even they always feel like sleepy, fatigue, tachycardia, palpitation, SIBO overgrowth, small intestinal bacterial overgrowth, restless leg, increased infections. These all are the sign of this iron deficiency. Iron, we have to give the iron up 100 to 200 mg per day, or 200 to 300 mg per day if the patient is deficient, and after that we have to shift the patient to the prophylaxis dose of up to 30 to 45 mg per day.
That has deficiency being fighted with the transfusion of.
With the transfusion, the iron yeah.
By quickly like that is directly and with the share to the last part will have been specific plus a 6 flat.
That we have to maintain it through the diet and exercise, because we can't retain it for and we can't give the iron administration for a longer period of time also, because hospital admission is required, and that's why we have to if the patient is doing the routine checkup, then
reasoning. There's a denominator of something. Where
Jalaju, dextrose,
civil what? I need to another whatever else doesn't any of this or ours, but in it. And everything you could play fitting another. 3 months to balance to the payment stay.
But in the bariatric patient, it usually not happen. In the bariatric patient, it usually not happen. We have to give them supplementation. After giving the iron supplementation to correct the deficiency, after that we have to give them the prophylactic doses.
Respond to because it does estrogen.
That's why I'm saying iron should be given in the form of iron bisglycinate. The form of iron is also very important.
But from the sophisticated
Iron bisglycinate.
deficiency.
These are the sources of the hem iron and non-hem iron sources. All the non-veg sources the patient can get the good iron, but through the non-hem iron, these are the raisins, dried and baked beans, whole grain bread. These are some good sources of iron. Even the chocolate, dark chocolate.
No, it's just what cool thing some days in that little more fit for see okay. That's I think the last thing was maximum of a video like that capable this some active or not very keen but
In fruits, we can't get the more iron as required. But just to give some part of the, that can. Copper deficiency is also very common in this patient. Hyperchromic anemia, neutropenia, and cytopenia, hypopigmentation of the hair, skin, nails. Whenever the patient is coming to the OPD, we have to check them clinically as well. If we are doing the clinical evaluation also, then most of the deficiencies we can, without any tests, we can.
I had this stage.
We can check their nails, we can check their eyes, we can check their skin. If there is a excess weight loss, then we have to check their fat. If sometimes patient is losing even more than 20% of the extra body fat, excess weight loss is there. In that case, we have to evaluate the patient very wait.
Glad to go to anemia, but it did anemia. I mean, that is me. What they did me out.
Just we are anemia. It could be just because of the copper deficiency anemia, vitamin B12 deficiency anemia, folate deficiency anemia, or iron deficiency anemia. We have to just through the lab values also we can check, and if the transferrin saturation is less than 8%, then it is related to the iron deficiency anemia, and we are finding more common kind of anemia in these patients are the iron deficiency anemia. Three to 8 mg per day copper glyconate or sulfate is recommended. And in severe symptomatic copper deficiency, we have to give IV 2 to 4 mg for 6 days, then oral monitor every 3 months. Pre-screen all candidates for bariatric surgery for vitamin and mineral deficiency. Monitor labs for all recommended micronutrient. Counsel patient individually based on the trend and severity of the deficiency. Encourage frequent follow-up and lab monitoring. Follow-up is very essential. We should avoid the loss of follow-up of the patient. Either we have to give in the if the patient is having the good follow-up, then we can avoid these micronutrient deficiencies. Even in some patient selenium deficiency also just because of that, one of the patient were having the ejection fraction just 10 to 15%. And patient lost more than 35% of their excess body weight, and the patient come to the OPD with this. And after doing this investigation, patient it was just selenium deficiency, and obviously protein. She was the JAN patient, that's why protein deficiency and other micronutrient deficiencies were there. We corrected those deficiencies, and the patient become normal. That's why follow-up is very essential. Otherwise, it can cause the damages that we can't reverse it, irreversible damage. Okay, thank you so much for your best. Yeah.
Well, he think that it's like the top site very nice label. The VT.
Yeah. Yeah. Okay, thank you.
Okay. We need to wait at what is actually glutamate? What anyway?
In the first week, we recommend clear liquid diet, just complete clear liquid.
But in the blues and water.
Juices we give in the diluted form, otherwise they can have dumping syndrome. In the next week, we can give the full liquid diet. In the third week, we can give the soft diet, soft textured food like mashed potato, mashed banana, yogurt. Soups, we can start here, liquid soup, we can start in the first week also. In the next week, we can increase the consistency of that food. And third week, we can start with the mashed food and like khichdi and even the soft diet, custard, all these weeks we can include. Third and fourth week almost same, and after 1 week, after 1 month, patient can have the normal food.